Good evening, ladies and gentlemen. Can you hear me well? Thank you everyone for joining us today. So my name is Aino and I will guide you today throughout this seminar. As a start, I would like to thank IBS Implant Company for giving us opportunity to gather all together and observe minimally invasive implant treatment concepts. Company was established back in 2008 and had its priority in patient treatment so that every single patient left satisfied with quality and results of the treatment. As a result of studies and the research, our company established academy where every single dentist can learn details and techniques of implant treatment. The Academy of Minimally Invasive Implantology teaches theoretical as well as practical hands-on trainings of IBS implant magic surgical system and the MAgiCore implant itself. We aim to create a clinician community who can perform treatment regardless of poor bone condition, of narrow bone width. We sure that they can be competitive in their practice as well as provide their communities with the most modern and advanced dental implant treatment. We hold regular courses 4 times a month and to deliver our knowledge. We continue to overbook seats at our courses, making us one of the most desirable training programs in the industry. Throughout regular symposiums and seminars, we introduce our Magic Guide system, which makes for more exact radiographic diagnosis and drilling, resulting in a guided surgery method which is even more accurate and easy to perform. And now let me introduce our first speaker for today with his lecture on basic concepts of minimally invasive implant treatment on example of MAgiCore implant. Dr. Zoltan Nyarady, Master of Dentistry, Doctor of Dental Surgery, Oral and Maxillofacial Surgeon, a guest lecturer at the University of West Hungary, National Speaker of IBS Implant in Hungary. Dr. Zoltan, the floor is yours. Please welcome.
Thank you very much. Let me begin sharing. Do you hear me well?
Yes, we do.
Okay, this is a great honor to be here in this OMNI-organized meeting. This is nice to meet you in this seminar due to the COVID-19 infection. Hope that the hard times go fast and we can meet in person soon. It is good to see you in later events also with OMNI. Let's introduce myself. I'm an oral maxillofacial surgeon based in southwest Hungary, in Győr, halfway between Budapest and Vienna, the capital of Austria. We just opened our practice with my wife and co-workers in March last year. The COVID also hit us hard, but luckily we were prepared for technically to treat complex cases, so we could easily cope with the changing regulations and could begin to give emergency treatment to patients. For the last 4 weeks here in Hungary, the things are getting back to normal and everything seems to be working, so we could proceed with normal treatment of our patients. This is how we work now. On the previous picture, you've seen us how we were working previously. And I also do work on a couple of other places, not on the sea. Something was mixed up here. I'm working in Hungary, a couple of places, and I do work in Norway in 3 places. Unfortunately, for the last 3 months, I couldn't go to Norway. They still impose a 10-day quarantine before you can work there. So my next trip there is planned in something like a month, and hopefully by that time, as Europe opens, we can also work there. This is my office. In this office, I work regularly, and I exclusively do use IBS implants. At the beginning, I was using for the last 3 years IBS FC implants, and for the last year, I began to use the MAgiCore also. I have to know that I was using the instrumentation of IBS for more than 6 years by now. Today, I will speak about MAgiCore. My job is difficult as the first speaker because I will have two excellent speakers after me, and they will go into different details and aspects. We may have some overlap, but they will give you on those fields much more insight. I will tell you and introduce you the MAgiCore. I also have to tell that this is not only a fixture, this is a whole system, and this is a whole concept of how we think about implants. I will introduce you first the company, then we go through a little theoretical part, then we go to the fixture itself, and then I will try to give you a couple of tips. What are the advantages and why to use the MAgiCore implant? The company of IBS Implant was founded in 2008. It got the KFD certification the next year. It began quickly expand to Pakistan, Iran, and Turkey. They have had the first IBS symposium in Turkey in 2013. They've continued further expansion. They are in China. They do have subsidiaries in China, Europe, in the United States. And in 2017, they founded AMI. In 2019, they already had the 5th AMI World Symposium in Seoul. This was a great event. It was really good to be there. And last year, they also established a subsidiary in Vietnam. They have plans that this year they are opening a factory in the United States. And they are involved in multiple research projects all over the world, in the United States, Europe, Russia, and hopefully soon in Hungary too. What you have to know is the company itself is located in Daejeon, Korea. The production line is an industry standard high-tech line. It has several random and systematic manual and automatic quality check procedures incorporated into the whole process of producing the implants and the tools. The products are both CE, FDI certified, and also comply with Chinese standard. The latter is quite hard to get because China itself is a very protective country when it comes to import things to them. So actually it's harder to get Chinese registration than anywhere else. They also received numerous awards for innovation within and outside Korea, among others, the most innovative patent, which is related to the MAgiCore implant, which we are talking about today. They are also recognized as holders of the 4th original patent within implant dentistry. And they are recognized United States, Europe, and Korea as the first premium brand implant. And I have to note here that in Korea, they are the first second used implant. And this is something big to a company which is not so old compared to the competition. How good is the product? How good is MAgiCore? You can see on this picture. If you take a look, you can see Dr. Wang, the founder of the company. And it is noted where the speakers from. They quickly managed to grab leading opinion leaders and speakers from Zimmer, Hemlock, Straumann, Nobel, and they very fast get a good working relationship with several universities within Europe. In 2017, AMI, the Academy of Minimally Invasive Implantology, was founded. This is an umbrella which incorporates all education, research related to MAgiCore. They had very good seminars. I happened to attend with my colleagues here, and a couple of very nice world meetings and local meetings. And they were responding very much to the COVID threat, also to holding several European, American and Asian webinars and webinar series during these hard times. So let's my real lecture begin. The original Brönemark implant in 1965 was a result of serendipity. It was a machine surfaced implant with an outer hex connection on a titanium screw. This is, we can tell, as the first implant, the first paradigm within implantology. The system laid down the foundation of today's implantology, but it needed improvement. The system had its bits: cortical bone resorption, screw loosening. In 1986, ITI designed a new tissue-level implant. The system had also its bits: cortical bone resorption, screw loosening. This solved some of the problems, but it was still there. In 1989, Astra introduced micro threads on the neck of the implants. This way they could handle better the cortical bone resorption around the neck of the implant. They also had a much more stable conical connection, which helped with the micro gap and the micro movement, but still retained the problems with the original implants. And in 2013, MAgiCore was introduced. This is a single piece implant, which, due to the unique being a one-piece implant, attacks all the problems with screw loosening and all the problems with an abutment. It has a very nice surface treatment, which is industry standard. So basically, the SLS surface works very well, and due to unique thread design, it handles much better in bone than previous implants. This is what I will speak about, and this is regarded as a fourth paradigm within implantology. The implant itself has a minimal post height, which is 2 millimeters. It has a variable cuff length, which is 1 to 4 millimeters, and it has an innovative thread for stress distribution. We'll speak about it today. It also has an external and an internal connection, which makes the Magic abutment a special connection. Let's go a little bit into implant design. If you go back to the original Brennemark protocol, all the steps which today's, the basics are today's implantology were already described and produced. The drawback of the original Brennemark protocol is that we have to have two-phase implants. That means we have to open the area 3 to 6 months after the healing period with another surgery. And this meant 2 surgeries to patients, and we also had this way more discomfort and more postoperative morbidity for our patients. In the next slides, I will go through the advantages of, In the next slides, I will go through the advantages of MAgiCore and the one-piece implant. You will hear a full lecture more in detail about it from Dr. Bruchowski, how the soft tissue is handled by the implant. Before we continue, let's take a look of the anatomy of the gum around the teeth and the implants. Here is a tooth, here is an implant. The junctional epithelium is attached to the teeth by hemidesmosomes, both in the case of a tooth and an implant. This junctional epithelium functions as a barrier between the outside world as the bone. It can be easily penetrated by a probe down to the bone, even in the case of a tooth, but it's much more vulnerable in the case of an implant. If you use a two-piece implant, the junctional epithelium detaches from the abutment, resulting in a deepened sulcus due to the micro movement and due to the fact that we also changed this part during the procedure while we make our crown. This will result in gum recession, and the connective tissue gets destroyed, and we will end up with peri-implantitis. How it's happening? On the right photo, you can see a detached peri-implant epithelium. This happens when the abutment or the healing abutment is removed. In cases of a two-piece implant, after soft tissue healing, when we take impression, the healing screw is removed. The wound is exposed, and we begin to manipulate near to the bone level. The newly developed hemidesmosomes connection of the junctional epithelium is destroyed. The junctional epithelium is detached, connective tissue is lost around the implant. When we reattach it, it will reattach, but it will go deeper. We have to do it at least twice, if not 4 or 5 times during a more complicated procedure. For example, when we make bridges. And this will result in undergrowth and deepened sulcus around the implants, raising the problems. If you look at the literature, it is shown that abutment and disconnection and reconnection significantly affects the peri-implant bone levels. If we use a one-piece implant, we do not need to remove the healing abutment, as with one-piece implant. We preserve the sulcus depth, we will have a complete connective tissue adhesion, and we will reduce the risk for bacterial penetration. This is also supported by the literature. When the implant is inserted, the soft tissue is growing into the fold, which is determined by the emergence profile of the MAGIC cuff. It will heal optimally. We will have a hemidesmosomal connection to the titanium surface, and this will be not disturbed in further handling of our implant when we build up the prosthetic parts. We will maintain ideological biologic width, and once the crown is seated, we can see on growth, which is basically the formation of a natural sulcus, very similar to that around the tooth. This is also supported by the literature that the gum margin is located more coronally, and the biological dimensions are more similar to natural teeth around one-piece non-submerged implants compared to either two-piece non-submerged or two-piece submerged implants. So it doesn't matter if you submerge or not submerge the implants, even in the case of ITI, which is a surface level implants, you will have some problems with your gum. When we compare the conventional implants to MAGICore, the conditions differences of the soft tissue around the implant are paramount. In case of conventional implant, the sulcus is located between the connective tissue and the abutment, resulting in a deep sulcus, and that forms aging parodontal conditions, resulting gingival recession and the possibility of infection. In case of MAGICore, the sulcus is located between the connective tissue and the crown. It resembles the healthy periodontal conditions around natural teeth. There is no gingival recession, and chances for peri-implantitis are more than tenfold decreased. After implantation, 4 months. This is immediately after implantation, 4 months, and 6 months with the final restoration. You can see the initial line of the gum. You can see the on-growth because the gum around the implant is not disturbed. There is no micro movement and no micro leakage. From soft tissue, let's move over to bone. Available bones sometimes make surgery challenging. Traditionally, to cope with unfavorable ridge, we have the possibility to use GBR, or we can remove the cast in case we have changes in the crest. And there's also possibility to use change shape of the implant. In case of narrow bone, one may use GBR. We may use a narrow implant, but then we have to be aware that we will have some durability consideration, and also this functional surface will be smaller. If the available bone height is not enough, one may use a GBR in a form of a sinus lift, open sinus lift in the upper jaw, or in the lower jaw, the sausage technique by Dr. Orban. Or we can use a short implant, but then we have to consider a bone amount which is actually supporting our implant. One way to fight this is, and avoid all the compromises, that we match the implant to the patient's bone. The bone and gum above the fixture is considered as a soft tissue. That means we'll need several types of heights for this implant. You can see that this amount of bone above the fixture is different height on the X-ray too. Using a strong connection, a bone-driven concept can be applied. The implant and the crown may be angulated, and we change from a prosthetic-focused to bone-focused implant insertion. We will need to design our rehabilitation still from crown down, but our surgical possibilities will be drastically improved. Issues may arise from the location and angle discrepancies between the bone and implant and our prosthetic components. Clinically, the shape and location of the crown is determined outside the soft tissue, or problems may arise from the existing abutments, what we do have here, that if we do have protruding abutments, it will limit our prosthetic way of rehabilitation. To solve this issue, the abutment should be designed not to protrude outside the gum. The MAgiCore abutment is formed. This is a hollow connection. When we use a cemented crown, more than 50 degrees of maximum angulation of the crown is possible, and we will just need a mere 3.5 millimeter of bone level compared to 5 millimeters when using a traditional implant with a cemented crown. And then also the maximum angulation of the crown is less than 35 degrees. When using the screw-retained restoration, the prosthetic advantages are even more profound because of the hollow design of the connection. No forces are transferred to the screw. Therefore, the screw is smaller. The hole for the screw is smaller. There are no micro movements, no loosening and fracture of the screw, while needing drastically less prosthetic space, allowing larger angulations and angulation differences. We will have a strong connection. If we have a strong connection, we will be able to have a couple of advantages. In cases of conventional implants, we do have an external or an internal connection. In the MAgiCore, we don't have it, so we will not have micro movement, we will not have micro leakage, and this facilitates healing while avoiding a lot of problems like screw loosening, the bone resorption around the implant, and downgrowth of the soft tissue. At the abutment level, we will have an external connection with its space and force limitation. The MAgiCore will have both an external and internal connection, a so-called hollow combined connection, giving lots of advantages. What are the advantages of this hollow connection? It gives the best of both connections. The internal part has an anti-rotational effect, has an increased resistance to lateral forces, while the external connection prevents wedging and gives structural durability. Now with the MAgiC abutment, connection of a bone-driven implant placement is possible. We have much more options to produce cemented or screw-retained restorations on our implants. In the MAGIC abutment, we have a connection with outstanding durability. The phase of prosthetic restorations are the same as with traditional implants. We still have the possibility to make a cemented restoration, screw retained restoration. We can work digitally. We can work the traditional way. So basically the same system the system works as with the case of a normal implant. If you compare it to the literature and the competition, Noble come up with the 1-1 system. It has only a 25% angulation. This is screw retained, so you still have screw loosening and micro leakage problem at the implant level. It has only 2 heights, 3 platforms, and this is still a 2-piece. Also, one has to know that this has lab restrictions, so if you want to work with this system, you have to use the Noble laboratories to work with. Ontogel, which is a Straumann company now, in 2017 also come out with the Axiom TL, which stands for tissue level. They have a unique platform, which has its advantages, but also it's limited to 25% angulation deviances. It is still screw retained restorations with all the problems of it. It is has 3 heights, 2 platforms. You can get it both on 1- and 2-piece implants, but it still has some laboratory restrictions. And then look at history, and I tell you history because MAGICore came out in 2013. It has a much higher angulation depending you make a screw retained or a cement retained bridge or crown restoration on it. You can have both screw and glue retained restoration. You have 4 height variations. You have 2 platforms. This is a 1-piece implant. No lab restrictions, so you can work with any lab you'd like to, from CAD/CAM to whatever you would like. And the advantage also that you will have a reduced prosthetic space depending if you make a cemented or screw retained restoration to 4.5 to 3 millimeter. 3.5 millimeter is enough from bone level to the opposing teeth. Now let's focus on surgery. Most competing companies have very complicated drill protocols. You can see how Alphadent is working with their kits, how complicated it. No wonder why you have to learn it. Then different other companies try different solutions, but most of them come up with very complicated trays, and depending the complication, what of their implants are you using. And the contrary, IBS has a very straightforward, very simple tray, which is easy to see and doesn't have too much instrumentation. When we come down to drilling protocol, other companies do use this very complex trays because they have a very complex protocol. They usually have a primary burr, and then they use several types of series of burrs to burr to the whole volume of the implant. Then they have a special burr to remove the crest. Then they have to tap, and finally they make a form drilling maybe and insert the implant, which only is different settings on your machine, making the whole thing more complicated. And this is the drilling protocol from different company. You see that you still need a series of drills. This can be in some cases simpler, some cases more complicated, but this is a very time-consuming and very complicated procedure. In the case of MAGIC drill, we have a very simple box. We have a very simple instrumentation and a very simple use for that. First, we'll use the pin drill, drill in our guides, make a CBCT scan, check for the aim, then use a special hole drill, which is the MAGIC drill, drill to the angle and the depth which we determined on our control CT. Then we check the depth, remove the depth, we make a form drilling with a final tap and insert our implants. And we step back a little bit and we look at it. I'm working because I'm a traveling surgeon with several implant systems. And when you begin to use a new implant system, you have to be aware how it works, and you have to drive them, insert them, and use them a bit differently than usually you do with cars. You can drive a car, you can drive an SUV, you can drive a Tesla, you can also drive a Ferrari, but to get the most out of the Ferrari on the track, you need different drive skills than normally you would use. Also, you have to know the limitations of your cars. Maybe this is the fastest, but it will not take you anywhere, especially if you have dirty roads. Let's go back to implant design again. In case of implant micro and micro design, this plays this significant role in overall success. Its physical and physicochemical characteristics determine the osseointegration, the load transfer to bone, and also how it is best to insert a given implant, its relation to bone and the surrounding tissues, and also the prosthetic possibilities. We always have to look at it as a whole system, including insertion protocol and the requirements for insertion, which can be very different between certain systems. This will determine the healing protocol as well as the possibilities of prosthetic rehabilitation. Traditionally, we have a drilling protocol, which I mentioned you. We have a pointing drill, then we have one drill, and we have a series of drills which still reach the diameter of the implant. In case of the MAgiCore implant, we have a first drill, then we tap, and finally we insert our drill. It's much, much simpler. If you look at the literature, it also supports that simplified drilling presents significantly higher initial bone contact after a week, which is a big advantage of better healing. Also, the simplified drilling protocol produces the similar or less heat than conventional protocol. And my third article says that low-speed cutting procedures do generate little heat, and consequently, osteocyte viability is maintained. The lack of irrigation, coupled with the unique design of the cutting fluids, channels into the osteotomy autologous bone chips and osteocoagulum that have inherent osteogenic potential, greatly increasing our immediate postoperative healing. We have a hollow drills which allow for higher speeds. First, we drill with this, and depending on the hardness of the bone, we remove the core, and finally, we use the final form drill. We can use a small aiming device that goes in the same axis as we made our initial drilling. And you have to remember that this protocol was made early. No will now come up with the N1 with a similar protocol, but MAgiCore was there from 2013. And this came out last year already. Let's go back to implant thread design. When the implant site is prepared, we need to select the right implant. Selecting an implant with thin rectangular thread reduces the bone trauma during insertion. This eliminates the bone compression. During loading the implants, the thin MAgiC thread, the matching elasticity of the thin threads transfer load to bone with less stress. Selecting the right implant thread will have a favorable stress distribution. There will be no shearing forces by the transferring load to the bone. Due to the mechanical qualities of the thread design, we achieve primary bone healing. There will be no bone chipping and condensations. Physical properties of the insertion are not naturalized. There will be little no chance to microfractures and shearing forces during mastication. We also gain a good initial stability by achieving morphologic contact between the bone and the threads. Implant with a thin thread is recommended for soft bone according to three-dimensional finite element analysis. If you look at the implant thread design, we have to know that the interthread bone, in the case of a traditional triangular thread, will damage the bone. And because this interthread bone is damaged, we have to still have 1 millimeter of undamaged bone on both sides from the side of the threads. Because this initially damaged bone first needs to resolve, and only then will we have new bone. A new method of securing primary stability is needed because the interthread bone should not be damaged during placement. We will reach stability with morphologic contact. For this new thread design was needed. When we design the system well, during surgery, the periosteum will not be detached and cortical bone is not exposed. We can perform flapless surgery with much less post-op morbidity and no bone resorption. The bone and the implant should join like the Lego bricks. Dental implant threads transfer occlusal force onto the alveolar bone like gears. If the load resistance is not the same between the two gears, the weaker of them will break. When comparing the resistance to loading forces of bone and titanium is 1 to 9, the thickness of interthread bone should be 9 times thicker than the titanium thread itself. When comparing the resistance to elastic forces of bone and titanium, the ratio is 1 to 10. The thickness of interthread bone should be 10 times thicker than the titanium thread. The required bone width is 2 mm greater than the diameter of the body of the fixture. And this is the difference that in this case, because the interthread bone is not damaged, we measure it from the core of the implant. That's why we will need much less bone from the side of the thread, which is given as the diameter of the implant. Application of the concept of matching of physical properties between interthread bone and thread. This titanium bone ratio is patented. To fulfill the requirements, the titanium thread must be rectangular. In shape, its thickness must be less than 0.15 millimeters. The forces transferred to the bone are controlled. According to finite element studies, if you take a look at the case of traditional implants, most of the forces are transferred to the bone on the coronal 3 to 5 millimeters, and this is usually which results in cortical bone resorption. But in the case of a magic thin thread, you will have an even transfer of forces during the whole length of the implant. The placement method also varies according to implant design, and bone width, which is 2 mm greater than the diameter of the fixture, is required in the case of traditional implants. In the case of magic thin thread, we have to perform a fit drilling. We use a basic preparation for that because we use hollow drills. We can use high RPM. We do not need to do the usual pumping, and we use intermittent force. We maintain our direction, and we have to reach our desired depth. Once we are finished with that, we do a fine preparation with low speed, high torque, and we should not apply any vertical or lateral force. We have to match the path of the basic preparation, and we have to keep in mind that this will be the path of our implant insertion also. We do insert the implant by hand, which should match this axis. The primary stability in the case of a magic thin thread will be not determined by the insertion torque, but by the fit drill. We also need to immediately reach the predetermined depth with our insertion. Because the interthread bone volume is large and we have fit drilling, direct connection with the bone healing is fast and primary stability is high. If you take a look and compare the MAGiC implant to traditional implants, you can see that how bigger is the volume of the bone which we are in contact with compared to two traditionally similar sized implants. And let me show you a case. You can see here is, it will be an immediate implant case. It's a courtesy of IBS implant. They had these two teeth extracted. The red line is the soft tissue. The yellow line is the hard tissue. The implants were inserted. And if you compare the original bone level, here the bone level, and here the bone level, you can see the bone height gain, which is unique to this implant. This is the measured gum, lateral, and the view from above, and the final restoration both in the upper and lower jaw. You can see beautiful gum margin. On the CBCT, you can see that the bone actually grew and climbed up along the implant. What are the advantages of MAGICore? First, the MAGiC fin thread. It gives stability by morphologic contact. There is almost no pain after surgery because we can use minimal invasive techniques for implant insertion. We can use the implant also in our ridges. The second is the MAGiC cuff, which is strong and gives a strong and resilient gum seal. We will have low chances of infections, and it will also maintain good periodontal health. It is a very strong connection, so we will not have any screw loosening, and we will not have any rotations. If you use a conventional triangular thread, we will apply excess damage to the bone. This is due to the triangular shaped thread. We will damage this bone, and this will lead to initial bone resorption, decreasing our initial stability. If we have a MAGiC thread with good initial stability, which is rich that we have good and undamaged interthread bone, we will have a faster healing and better immediate stability. The function of the MAGiC fin thread is to stabilize the implant, because how it is made, we can use it in narrow alveolar ridge also. We have several sizes, which is much bigger, and we have a much better selection than the competition. The stress distribution is different between a traditional and fin thread implant. We will have outstanding stress distribution. This way the functional surface is extended, because basically we can see in a case of a normal implant, it's only the first 3 to 5 millimeters, while here we can count with the whole length of the implant. We have several sizes, both for the cuff and the fixture itself, which results much more flexibility in insertion. And if we look at the MAGiC abutment, we have much more possibilities for prosthetic rehabilitation. The junctional epithelium will be spared. It will be healthy. We will have connective tissue adhesion. We will have a one-body structure, and the MAGiC fin have its advantages, which is outstanding stress distribution due to its macro design, also because we have this large volume of interthread bone, and we will have an extended surface of bone, so we will have increased initial bone contact, and because of the surgical procedures, we will be convenient inserting these implants. So now let's go over and I will show a couple of my cases. This was my first case. He's a 40-year-old, absolutely healthy patient. You see how much bone he had. He was missing tooth 1.5. We opted for MAgiCore. This is the intraoral picture preoperatively. First, you measure the gum. Then you drill your magic pin. Once the pin is inside, you take a control CBCT. On this, you check the angulation, the position of your pin. You also do check which size of fixture you will need. Then either you make a mini incision or you just drill through the gum. You make your drilling. After the initial drill, you do the final papping or foam drilling. Take your beautiful MAgiCore, which is selected by how much bone you have. That's how you select the fixture, and according to the bone above the fixture, which cuff you will select. You have 3 sizes of width for the head of the implant. This is selected which kind of tooth you want to replace with. Inserted the implant, then you put the covers through. This is the postoperative combine CT. In these cases, I also always do use a post-op combine CT to check my results. You can see that in this case, I needed to change my angulation a little bit compared to the original one. This is 3 months after. And now let's go to the second case. This is not so recent case. It is a middle-aged male who is healthy, non-smoker. He had a good amount of bone, would have liked to have minimally invasively inserted implants. He did have some compromised gum. So one of the options was to make a gum surgery with traditional implants. But because of the minimal invasive surgery and because of the MAgiCore, we didn't need that. Drilling of the guide pin, insertion of the 2 guide pins, CBCT with the guide pins. This is the guide for the final drill, and then the control CBCT with the inserted implants, and finally the intraoral picture. The healing time will be 4 months, and after 4 months we'll load it. Thank you very much, and hope that soon we can meet in person in a different lecture. Thank you very much. Sorry, I cannot hear you.
Thank you. Can you hear me now?
Yeah, sorry.
Sorry, there was some technical problems with my microphone. Thank you very much, Dr. Zoltan, for such a detailed explanation on the MAgiCore, and especially thank you for sharing your cases. It was very interesting. Really something new approach in that field. I really appreciate, and as you said, hopefully we will have a chance to meet again soon in a live lecture.
Thank you.
Thank you.